So there was one gentleman in particular I took care of for a lot of years, and he ultimately died. I was with him in the ICU literally only hours before he died. At that point in time in North Carolina, we had not expanded Medicaid, and that's our public payer coverage to help people access healthcare. And he didn't have any children, and so he didn't qualify for any sort of benefit to him. And actually at that visit told him that it was done. He wasn't going to make it this time. Repeated the cycle until it killed him and he died.
Yeah.
He didn't need to die. We had a treatment.
Welcome to Medical Portraits. My name is Carl, I'm a physician, and in this podcast, I talk to inspiring doctors who have extraordinary stories to share. My guest today is Dr. Shannon Dowler. She's a rural family physician, health policy leader, author, and musician, and she spent her career fighting for better access to care for underserved populations. Shannon served as the Chief Medical Officer of North Carolina Medicaid, where she helped expand coverage for hundreds of thousands of people. She also has what she calls her side hustle, bringing humor and creativity to sexual health education. In this episode, we talk about her journey from family medicine to the front lines of health policy, the challenges facing Medicaid today, and why sexual health needs a more open conversation. Great to have you here, Shannon. Wonderful to talk to you. Thanks for making the time. I heard you on a New York Times podcast and found out that you live in North Carolina in the Appalachian Mountains, and I've never been there. I have like a little bit of an image of what this might look like, what this might feel like, but I live in Berlin, so it's probably very different from reality. So maybe you can paint us a little picture. What do you see when you look out the window? What is it like to live in your area?
Yeah. So I live way up in the mountains of North Carolina in a very rural community. So I definitely have more cows as neighbors than people. When I look out my window, I just see mountain ranges. I see probably 3 or 4 layers of mountains out the window. It's very green right now. The leaves haven't started changing colors. My neighbor just mowed our hay fields, and so I've got big rounds of hay sort of peppering the landscape in front of me, and it's really kind of lovely. And then if I listen carefully, I can hear my goats yelling at me to give them more food. So I've got goats and chickens and cats and dogs, and I'm living the rural mountain life.
Yeah, I have this even more romantic view right now. So, but I also imagine like if we start thinking healthcare, like where I live, I think probably the nearest hospital is 10 minutes, and this is probably true for anywhere that I usually am in the city. So I'm wondering, or I can imagine that this is slightly different. Like what kind of difference in practicing medicine is living in an area that is a little bit more remote than the bigger cities?
So my clinical time is split in a few different places, and so I don't actually practice in the community that I'm living in right now. My husband woke up with a kidney stone about a year ago, and the closest emergency room was about a 45-minute drive,
Oh.
and it washed away during Hurricane Helene, which you guys might have heard about, was a big natural disaster we had here in Western North Carolina last fall, almost exactly a
Mhm.
year. And so that hospital's gone now, and so it's about an hour to the closest emergency room now from where we live. And it's not an easy hour. It's up and down over mountains. So if someone is transportation limited, it can be really hard. There's only primary care in our county. We have some family docs, but we don't have any specialist of any type. There are no psychiatrists, no OBGYNs. Our health department and a federally qualified health center provide the vast majority of the health care in the county.
Yeah, I can imagine like not just for kidney stone, but if I imagine that we had a similar situation and we were quite happy that we didn't have to go over mountains for an hour to drive to the nearest emergency room. In general, how did you get into family medicine? Is this something that you grew into, or is this something that you discovered along the way? Can you tell me a little bit about that?
Yeah, sure. So I always thought I was going to be a veterinarian, that my plan was I was going to take care of animals. And so from the time I was 13, I was working in vet hospitals, cleaning cages, doing what they let 13-year-olds do. And I stayed working in vet hospitals until college. And then in college, I started to really think about the world differently and sort of add a social justice framework to the way I thought about the world. And I started kind of questioning if I went into medicine and kind of took care of
Mm.
underserved populations. As you know, in the United States, not everybody has equal access to healthcare. And so I did a couple of rotations and internships at the local community hospital where I went to college. and really fell in love with it. And at that
Mm.
point in time, as I started looking at medical schools and learning more about the medical landscape, it was really clear to me that family medicine was the place that I could have the biggest impact on all ages and stages, but also professionally have some flexibility. And so my career has followed this really sort of strange and circuitous path. And I've been allowed to do that, I think, because I'm a family physician. And so I've been able to do all sorts of different things.
Yeah, very interesting. And I'm very interested to hear more about the detours or unexpected lanes that you've walked down in medicine. But looking back, like, or reflecting back on your decision to start family medicine, is there anything now, having the experience for decades in the field, that surprised you looking back, or something that you would not have expected at the time when you started?
I think I didn't understand how many different paths a physician can go on. There's just sort of this sense when you're a student that you'll just become a doctor and you will see patients all day, every day. And then suddenly the world becomes much bigger. And you're just by virtue of the fact that you're a doctor, you become a leader in your community. And
Mm,
then from there, you have to decide, is advocacy the path that you want to go on? How do you want to use that opportunity and the platform you have as a physician? Because generally speaking, physicians are respected as a profession.
mm,
And so I chose to stay in underserved care. I've always worked in the service of nonprofit organizations and trying to take care of the most people. And that actually has taken me on this pathway through a more administrative role at times and leading at the state, now at the national level. And so I don't think I understood when I was a student that particularly being in family medicine and learning expertise around children and pregnancy care and geriatrics and behavioral health, you kind of have to learn all of it to do that work well. How much
yeah.
of me and but also advocating and being more active around supporting care access.
And would you say that you kind of got pulled into these administrative roles or advocating for policy as a result of your work, and to work for maybe underserved communities, and your direct impact you had with patients? Or was this something that you actively were seeking out? Like, how did you get into this field?
I don't think I had any idea that's what was going to happen. I think a couple things happened. One, I started really hearing people's stories in the exam rooms and watching how poverty impacted healthcare and health access, and how it was literally watching people die from preventable diseases or
Mm,
things that we could have treated if they'd had health insurance, and instead they died from those diseases.
mm,
And hearing people's just heartbreaking stories that these were hardworking people who were suffering, and they were suffering because we had not afforded them access to healthcare. And so I got really passionate from that standpoint of seeing people's lived experience. And then I also am a very impatient person. And so I couldn't, when things weren't working in the clinic that I was in or in the health system I was in, I just needed to change it. And so I was like,
yeah,
this is silly that it doesn't work. We must change it. And so that just pulled me into a leadership track that I don't think I knew was coming, but
mm.
it has served me well.
Yeah, fascinating. And also, I mean, very comprehensible. If you see that suffering in front of you, I'm sure that does shape you, right? And we all have these patients that stick with us, and that sometimes maybe change something within you, that makes you want to go beyond just solving this one case, but more serve more like a general, or improve things on a more general level. Are you free to share like one example of a patient maybe that sticks with you, where you think like, oh, this is something that is so unjust that I was a bit nudged more towards the direction?
So many, there are so many potential stories. So there was one gentleman in particular I took care of for a lot of years, and he ultimately died. I was with him in the ICU literally only hours before he died as a visitor. I wasn't his attending, but I went to see him, and actually at that visit told him that it was done. He wasn't going to make it this time. And I had seen him through numerous hospitalizations, and he had liver disease. He had end-stage liver disease because of hepatitis C virus infection. And he
Mm-hmm.
used alcohol because he had bipolar disorder that was untreated, essentially. And so at that point in time in North Carolina, we had not expanded Medicaid, and that's our public payer coverage to help people access health care. And he didn't have any children. And so he didn't qualify for any sort of benefits. And so for him to get his hepatitis C treated at that time. He had to be completely clean of alcohol and he couldn't have any mental illness, but he had no access to psychiatry care. He had limited access to medications. And so getting him through his alcohol abuse, which is how he managed his bipolar disorder, was this really complicated pattern of him doing well for a while, getting stable on medicines, feeling kind of hopeful that things were going to get better. And then, some crisis in his life causing a relapse. And he was working through all of this. And then he would get encephalopathic and we would get him admitted and we get his levels down. And then he would do well for a while and repeated the cycle until it killed him and he died.
Yeah.
He didn't need to die. We had a treatment for hepatitis C. We had better ways to support treating his alcohol abuse and his bipolar disorder, but we just didn't have access to all the tools in the toolbox.
Quick break, I'd like to hear from you. I'm making medical portraits to inspire you, so I want to learn a little bit more why you care about it. What topics would you love to hear more about? What guests should I invite? What part of the podcast do you like and what parts maybe don't you like so much? I'd love to hear your honest feedback. You don't have to spare my feelings. Just send me what's on your mind. On one more thing, I've recently been mixing English and German episodes, so is that okay for you, or would you rather just to have one language and not mix it up? Whatever your thoughts are, please share them with me. The easiest way to reach me is via email. Just send me a mail to medicalportraits@gmail.com or just reach out on Instagram. The link is in the description. Yeah, looking forward to hearing from you. And you mentioned Medicaid, and that's where you ended up actually being the CMO for, I think, a few years, 5 years in North Carolina. Not all of my listeners, me included, fully understand what Medicaid is. So maybe you can give me a little introduction on what Medicaid is, who it's for, and maybe also elaborate a little bit on the expansion that you mentioned and what that was about.
Absolutely. Yeah, it's you live in a very different healthcare world than I live in. And as a matter of fact, when I was a resident, little sidebar, I decided I wanted to see what socialized medicine was like. And so I scheduled a 6-week elective rotation in Reading, England, just outside of London, to really understand how socialized medicine worked in a community. And it was amazing. I did family medicine and obstetrics during that time. The joke was that the very last week we were there, when I wasn't working anymore, we were going to travel around with our 1-year-old and see the country. My husband got an acute appendicitis and had to have major surgery. So we really
Lucky.
we really got to experience it. Medicaid is one of several ways people can get health care in the United States. Medicare is really geared towards older adults and people with permanent disability. Medicaid is for lower income adults, and they're usually women, pregnant women and children, or adults that are low income, what some people would call the working poor. So people that are in service jobs, maybe working for places where they can't afford the benefits, because the third way you get access to healthcare is through commercial insurance, which is very expensive. And so if it's not a benefit through your job, most people can't afford to just go out and buy it. It might be thousands of dollars a month for someone to buy that insurance. And so if you're working at a fast food restaurant like McDonald's, you probably can't afford to buy that for yourself. And so in the country, when Obama was president, he passed through the Affordable Care Act an expansion of Medicaid so that people who were low income adults without children, essentially, could get access to Medicaid services. So people like my patient who died from hepatitis C, which is a completely treatable, liver infection, could access all of the resources of care. And so what it does is it ultimately improves the economy of the state that you're in. You have a healthier workforce. More people are able to return to the workforce and be part of the workforce. But Medicaid also pays for low income seniors. So older adults that have Medicare coverage, once they become institutionalized or live in a nursing home, they depend on Medicaid to pay the difference of the cost of being in a nursing home. And it also takes care of everyone in the country that's got an intellectual or developmental disability that they become disabled from. And so it's a really important access to healthcare for a lot of people in the country.
And I understand that the patient you mentioned in your story earlier didn't have access to Medicaid, but there was an expansion signed through the Affordable Care Act by the Obama administration in 2010 or something. And as I understand, that didn't come into effect everywhere, but it eventually happened. And was this during the time that you were at Medicaid? Can you tell me something about that?
Yeah, so North Carolina did not choose to expand Medicaid. Medicaid is a program that's largely federally funded with a federal match, but it's under state control. And
Hmm.
so every state can decide what they're going to do with their Medicaid program. But so what you saw during the Obama years is that states who are generally liberal um,
Hmm.
adopted Obamacare rapidly. So what people
Hmm.
called it was Obamacare, and they expanded Medicaid. And so they had access to all these resources, and you saw the health outcomes from that state get better and all these things. And then along the partisan lines, states whose leadership was largely opposed to that political platform often chose not to expand Medicaid.
Yeah.
Well, over the course of a decade, you saw more and more of the red states or the more conservative states say, okay, actually, as we look at the evidence and as we look at what happens, it's really good for the economy and it's good for the health of these states to do it. So we'll go on and do it. And so I was lucky enough to be at Medicaid as the CMO. I was there for 5 years when North Carolina, and through bipartisan work, we had a Democrat governor and a fairly conservative Republican legislature worked really closely together to say, okay, how
Yeah.
can we make this happen? And we did it. We made it happen. It was almost a year and a half ago. And so people like my
Yeah.
patient died, and like the countless others I've taken care of in my career who suffered or died now can access services and
Yeah.
get the health care they need. But of course, with some recent legislation changes, there's some risk
Yeah.
to that.
And I think I'm going to get to that in a minute, but I just want to say, like, this sounds like what you experienced there was a great success because, as you explained it, right, it seemed to be a little too partisan and maybe not enough focused on the benefit of the healthcare system so much. And somehow people ended up working together and made it happen, right? And basically gave access to a lot of people to the healthcare system that didn't have access before. And now, as you mentioned, there's another setback, it seems like, with this other big piece of legislation that was signed earlier this year, the One Big Beautiful Bill Act signed into effect by the current Republican administration. And what this essentially is, it's like a huge piece of legislation that I don't really fully understand either. But like a lot of what it seems to be about is to implement tax cuts that cost a lot of money, and the money has to come from somewhere. And one of these areas where they need to save money is Medicaid. And so essentially, there are cuts that have to be made for Medicaid again. So, what are the consequences of this new bill and what changed since this has been put into action?
So the federal match, which is what the federal government pays as a portion of the Medicaid cost for a state, is usually half to two-thirds of the cost. And so it's a huge piece of the budget, is how much money we spend on Medicaid. But when you actually break it down and look at who that money goes to, it's mostly seniors who are in long-term care facilities because they're
Mhm.
older adults that can no longer live alone, or people with intellectual and developmental disabilities. And so it's tough because that leaves you a smaller pool. It's not very politically attractive to cut services to those populations. And so that leaves a smaller group of people that will be impacted by the changes in the HR1. That's the other name we call it now. And it's actually a whole variety of impacts that will happen over a period of time. But what
Mhm.
we're seeing is in advance of that, some states are already going on and making cuts because they're worried about what's going to happen to their budget and that they're going to have state budget shortfalls. But essentially, the biggest piece that goes into this is work requirements. So
Mhm.
saying that in order to qualify for this Medicaid benefit, unless you have one of the handful of exceptions, you have to prove to us that you're working. And if
Yeah.
you're working and you're still low income and like really low income, this is not people that are doing well financially, then okay, fine, you can keep your Medicaid. But every 6 months, you're going to have to go through this paperwork process to re-justify that you should actually be on this. And some of the work requirements will potentially even happen monthly, where people will have to every
Yeah.
month. How do you do this when you're if where I live in rural North Carolina, we have a lot of farmers. They don't have a boss. They are the boss. How are they going to demonstrate these work requirements? Or people that are nursing assistants who are doing in-home care for a family, who are doing this on their own, or they're caregivers and they work very part-time on the side. but not necessarily in a way that there's an easy way to document that work. A lot of people are working as independent workers. And
Mm.
so there's all these complications around how are we going to implement these so that everyone gets credit for the work that they're doing? And how do we do it in a way that people don't lose their coverage? And when they've done this in a few other states around the country, the studies have shown that actually it doesn't save any money. You do have people losing coverage, but you still have to
Yeah.
pay for it. They're just unreimbursed care. They just show up in the emergency room with their heart attack or their cancer, and then they get on Medicaid. And so they have been very effective at controlling costs.
If you're delaying the problem and let it grow and simmer until you can't, deny them access to treatment because it's an emergency and you need to act now and right away. One of the things that came to my mind when I read about the Appalachian area, I heard that it used to be like big and coal, right? Big industrial area. This reminded me a little bit of the counterpart in Germany. And maybe there are some cultural reasons for that as well, because I don't know about Appalachia. In the coal regions, the general culture of people is they're tough and they're proud, right? And being tough means that you don't really go to the doctor for every like little thing. And being proud means like if we make it too complicated for you, you're gonna say like this is like not I don't feel comfortable doing this because I don't want to be looked down upon. So I'm wondering like maybe is this an aspect of this whole debate as well?
Yeah, it's very much an Appalachian culture phenomenon as well. You have people who, for generations, have been farmers or worked for big service industries, and they're proud of the work that they've done, and they're proud of their independence. And when they have to go for healthcare that they cannot afford, they don't want to go into debt. One woman I took care of with a very advanced breast cancer just didn't want the medical debt that would happen. She knew she had something very, very wrong with her, but she was terrified it would bankrupt her family. And so she just didn't seek care. And so you see that pride of not just, I don't want to ask for something that I can't pay for, which feels very shaming, but sometimes the healthcare system's not good to people. And if the first thing when you call to make an appointment, everybody asks is who's your insurance, that makes people that don't have insurance feel immediately ashamed of how they're going to show up in the healthcare system. So people avoid care and they delay care. And that is very typical. And I would say in rural populations and in sort of the working poor populations.
Yeah. And what's happening now? How are you going to tackle this? Is there anything that you can do, or is this something that for now you just have to accept to some extent? Is there a window of opportunity somewhere down the line? What are the next steps?
Well, I think there's a lot of hope that Congress will actually roll back some of these things. There's no guarantee that that'll happen, but I think
Mm.
there's hope that that will happen, that there will be some softening of some of the language and some of these changes so that they don't impact people. You can't count on that. You can't take that to the bank. And so,
Yeah.
meanwhile, your safety net systems. So, in our country, we have free clinics that are manned by volunteers. That's where some of my clinical time happens. I volunteer at a free clinic. You have federally qualified health centers who get some subsidies from the federal government. You have local health departments. And so all those safety nets are really
Mm.
pulling together to see how
Mm.
can we shore up the population
Mm.
and how do we help hold them up when they start falling through the cracks of healthcare again and they're on and off coverage and they're on and off their meds and their diabetes is suddenly wildly uncontrolled and they're starting to lose their vision or need an amputation. Like, how do we catch people? And then how do we help them make sure they're doing their attestation for their work requirements? And how do we keep them in care as much as possible?
Yeah, so yeah, it seems like a long way to go, but at least I think there's maybe this sense among the healthcare community or healthcare leaders that you can actually try and do something about it. Maybe we can go away a little bit from the policy and go back to you because I'm wondering now, being a physician, being a family physician, and then taking a lot of steps in becoming the CMO of Medicaid, which I imagine is a rather large organization. Like, how is this challenge for you? I can only imagine that this is a very different kind of work. You're surrounded by very different kind of people. Your role is completely different, right? You're usually, I think, as a physician, as you laid out earlier, you're a respected person in the community. But if you're in a large organization, you have to earn your respect in a very different way. So how is that experience for you?
It was a huge learning curve. Going to work for state government is a massive undertaking. There are 3 million patients that get Medicaid coverage in North Carolina alone. So I was the chief medical officer for an organization that cared for 3 million people, which is, a lot of people, $20 billion in our budget. And I started looking at spreadsheets and financials with a really different lens than I looked at them, from the independent practice side of life where you're looking at much smaller numbers of things. It taught me how important it is to, one, listen to other government agencies. So what's everybody else working on and how do we work smarter together and get further faster by collaborating and, historically. And so that was a big challenge, was figuring out how to sort of work with other partners to get more done with less. And then that community voice and how important it is that we're trusting our community-based organizations, our churches, our community centers, those people on the ground that people really trust, how they can help them go further. And I think too, this reliance on how critical primary care is and how that infrastructure, that medical home, if everybody just had access to a medical home, we would solve so many of our problems. But in fact, a lot of people don't have access to a medical home. So a lot of my time was spent making sure that I was doing everything I could to shore up the medical homes, making sure that we were providing as rich a benefit so that family doctors and pediatricians and internists would take our patients with Medicaid and make sure
Yeah.
that they have access to care in their communities. So there were all these sort of different facets. And then also leading with other state chief medical officers from around the country and understanding that even though I might be having a bad day in North Carolina, my buddy down in South Carolina was having a way worse time of it. And so it was very interesting sort of seeing how it played out across, our very big country.
Yeah. Yeah, I bet. And as I understand, you're still practicing with patients. How did this experience maybe change your patient interaction? Do they know about it? Do they ask you about the bigger picture sometimes? Does it affect your work at all, or maybe how you see it?
Well, I think there are a few things. Thing one is that every physician leader, every physician administrator should have patient care time. Losing it altogether disconnects you from how hard it is to practice medicine and how
Mm.
complicated it is and how endless it is. And honestly, how broken healthcare is as a rule for
Mm.
people. It just doesn't, at least in this country, it does not work well for people most of the time. In the exam room and really seeing patients is important for understanding that as a doc, this is really hard work. And you could kind of forget about how hard it is to be a physician. It keeps you connected to the empathy and why when you're making big decisions that are going to impact people, you remember faces and names and stories. And it's not just this disconnected thing that happens.
Yeah.
The other thing I will say as a family doctor, I found that the more administrative time I got, the harder it was for me personally to maintain a panel of continuity patients. Doing that true full scope family medicine became more and more difficult because I was traveling around the state and the country and I wasn't there for my patients when they needed me to be there. I actually stopped doing continuity care, so long-term chronic disease management care, and really hunkered down in my favorite clinical area, which is sexual health. And so I've developed over 20 years and expertise in sexually transmitted infections and sexual health care. And so for the last 5 years, that was the vast majority of my clinical time, with the exception of free clinic time where I volunteer.
Yeah, and speaking of that, preparing for this interview, of course, I checked on what I could find, and looking at YouTube, I found great videos of you rapping about sexual transmitted diseases. One of the titles is STDs Never Get Old. It is connected to or based on the sound of Ice Ice Baby. Also really appreciated the monkeypox, don't touch that. Good raps. So yeah, kudos.
Yeah, I've always been a sexual health educator, so I've done talks for youth groups and church groups, and I'll talk to anybody about sexual health, including physicians. I do a lot of teaching to physicians as well. And I found that coming at education from a little different lens, like let's be a little quirky and have some fun with it. So I
Yeah.
started writing, recording, performing, editing. I do it all myself. I'm a one person show, with the
Yeah.
exception, yeah, it's sort of a fun way to help tell the story and get people interested in a topic that's historically kind of stigmatized and taboo.
Yeah. Yeah, I think it is an extremely creative way of interpreting education. I think it's important. And I wonder what the immediate reception is of a topic that maybe people feel uncomfortable around, especially on the patient side. I think as a physician, we're used to discussing this, but on the patient level, and especially when you're talking about the older generation who feel even more uncomfortable talking about these things, what was the reception like, or do you feel that this is changing?
Yeah, so it was so interesting. So my first rap video was like 5 years before my STDs Never Get Old, and the local news picked it up, and it got a little bit of play, like, haha. A couple school systems asked if they could use it, and I'm like, of course, and it's educational. It's for anybody. And then their filters wouldn't let them show them because it had words in it like, sex. So then I did this one, STDs Never Get Old, which I did because in my clinic, I started seeing people coming in older and older with syphilis and herpes. And, like this one guy's dragging his oxygen tank in with a herpes outbreak. And I'm like, what is happening? Like something is different in the world.
Yeah.
And so I did that one and it got immediate attention. It went viral for a brief period of time, like a week or
Yeah.
so. And I did a show called The Last Laugh in England actually called me to come. They wanted me to come be on the show and they wanted me to fly out that night. And I'm like, but I've got patients tomorrow. I can't do that. But it got interesting. Like it was linked to by Sports Illustrated, Breitbart, Mashable, all on the same day. So really from different perspectives. There was this interest in the sort of world to explore the topic. And it actually led to a book deal. I ended up writing a book called Never Too Late, Your Guide to Safer Sex After 60 with the Johns Hopkins Press, which of course did not make me independently wealthy because it's not really a topic anyone wants to read about. But yeah, I think there's actually a lot of interest in how we educate our older adults who are moving into retirement communities. I don't know if that's happening in Germany, but in the United States, a lot of older adults are moving into retirement communities out of these vibrant, energetic communities where people live together as they age and they're still healthy, but they don't have jobs. They got time, they got money, and so they're having sex.
Things happen.
So I think there's actually a lot of interest in the United States. The Bachelor, the Golden Years or something just came out last year where there is a special Bachelor series about older adults.
Yeah.
So people are interested in it.
Yeah, you seem to have struck a note really, and that really shows how it does matter. I'm wondering your observation that more and more sexually transmitted diseases appear in your practice within older people that you might not expect. How do you explain it? Like, what's the change in behavior? Like you mentioned the retirement communities, that might be one aspect, but do you have any other explanations for this rise in STDs?
Yeah, I think there are a few things that are happening at the same time. In the 1960s in the United States and the early 70s, we had what's termed the sexual revolution. That's where that generation got everyone really thinking about sex differently, very sex positive. That's where same-sex relationships suddenly became more acceptable to talk about. Well, that's the generation that's retiring right now. So it's the same people that taught us about sex in the 60s and how to think about sex differently. They're just older in doing it. So I think that's a piece of it, that there's this sort of generational truth. I think we're also have better living through pharmaceuticals. So we're able to help people have sex longer through treating erectile dysfunction, treating chronic diseases to avoid complications, hormone replacement therapy. We have all these ways that people can age sexually in a different way. And then the other leg of the stool is the hookup apps. We have this technology, right? We have all the social media and hookup apps. You can believe grandmas and grandpa are on the hookup apps at all ages. And maybe they're using them as a dating app to find someone to go out to dinner with or someone to go on a trip with, or maybe they're using them for casual partners. And so this ability to find people and meet people is alive and well for them as well for the younger demographic.
Yeah, it makes total sense. It's a new generation of people growing older now. They have grown up completely differently than the previous generation. You mentioned the technology changes, right? The apps. I'm also wondering, I saw a documentary the other day about the young generation who gets burned out from dating apps. I think maybe one chapter in your book was also on advice for older people to use dating apps. And I'm wondering if this is an issue, if, ghosting and all this, like, oh, there's so many people that I can choose from. If this is the universal problem, like, what is your advice if someone comes to your clinic and asks you about dating apps?
I think that there's good and the bad with these apps. I think they are absolutely directly related to an increased risk of acquiring a sexually transmitted infection. So when I look at my new hepatitis, syphilis, HIV cases, almost all of them have had a hookup with a partner through an app. And that's more of the sort of hookup app side, not the dating app side. And we know they can be a little bit different, but there's some crossover between them as well. So there's a risk there that if you're not careful and if you're not making good choices about your partners and having good candid conversations about their testing and using barrier methods, particularly early in the relationship, then you're a little bit more at risk. And I think there's also a psychological challenge that people do get kind of hooked on it. The older adults do as well, just like younger
Yeah.
people do. And if nobody's swiping on them, if they're getting rejected over and over again, it feels really bad to them, just like you would
Mm.
expect it to feel to a 14-year-old. And so there's a psychological component to it as well that's real. On the positive side, if someone's been married for 50 years and their partner dies and they're finally, it's a few years later and they're lonely, but they're healthy and they're going to live another 10 or 20 years, they don't want to maybe live alone for the rest of their life. And so it creates this amazing way for them to make new friends, to maybe start dating again, and to get into a relationship space. For some people, and maybe as a totally different person than you were in that 50-year marriage, because society has made it possible for you to be yourself in a different way than it was before in your life. And so you see older adults maybe for the first time exploring same-sex relationships when they hadn't done that for the majority of their lives. Unfortunately, they haven't had sex ed in 50 years. And when they had sex ed, they were like 3 sexually transmitted infections, and now we've got this like huge list. There's a menu of the different infections you can get from sex. And so I think this opportunity to do sex ed more with our older adults is important for us as physicians and not to be ageist. We can't just assume that because someone
Mm.
is older that they're not having sex. And I think we do
Yeah.
this in medicine all the time. So
Yeah.
how can we open the door, create a safe space for people to have really rich conversations about what's happening with them sexually as they age?
It's interesting, like the more you think about it also with your educational work and your YouTube videos, but also the book that you wrote on, on preventable sexual transmitted diseases, or even a webinar that I saw where you basically really engage with a very interested community and actually very open community. It really seems like physician work, right? Because that's what a physician does, right? It's just a new format. It's embracing new formats, new technologies. I wonder if we just in general need to be a bit more open on experimenting with other formats to get the message across, because it's not effective to tell everyone individually, but you need to kind of get some viral moments sometimes to get a spark.
And when I do talks for retirement community, sometimes they'll ask me to come and do a talk to a retirement community. And it's always people are kind of apprehensive. They're at the edge of the room. They're like, oh, I don't know that I want to have this conversation. But by the end of it, like they're engaged and they're asking questions and they're texting their grandkids to make sure they've gotten the HPV vaccine. Once you sort of open the door and create a safe space around these
Yeah.
conversations, it's amazing how interested people are and also kind of how horrified about how much they don't know. You can see their eyes light up and they're saying,
Yeah.
what? You can get an infection in your throat?
Right.
Important conversations we need to have.
Yeah, and it also shows that people still want to learn, right? They just want to learn in a safe space. Like when I saw your book presentation, it took you a minute to engage the entire audience, and it was like this great moment of everyone like shouting in responses that came to their mind, and it felt like a school experience, but everyone was very eager to learn more and share their thoughts on it as well. Very inspiring.
I find conversations are always fun.
Yeah, and you know, having been through so many different types of medicine in your career, the direct patient interaction, the policy, Medicaid, completely different role, and then this educational part, being an author of a book, like, is there anything that holds it together? Like what is the thing that keeps you motivated through all of these pretty big endeavors?
I think there are probably a couple things. So my mainstream job has really always been at its core about health access and really health access for underserved populations. So whether it's one-on-one in the exam room or it's at the national level, with programs that affect millions and millions of people, it's health access is my sort of driving force and that thread of things. My sexual health work, I always describe as my side hustle. It's the thing that I just get super excited about because it's a little off center and not everybody's comfortable talking about it. And so if I can create a space where people can feel comfortable talking about something or being better as doctors, talking to their patients about something, then I feel like I've also improved health access in that way. And so it's
Yeah.
all ultimately fundamentally comes down to health access. And I don't know. I don't it's a lot. It's been busy. It's been a busy career, but it's also like the next stage and next iteration of my career is always kind of more fun than the one I left behind. And so I think that's part of the beauty of family medicine is that you can sort of traverse different paths and some specialties you don't have that opportunity,
Yeah.
or you have to work a little harder to get that opportunity.
Yeah.
I feel lucky I picked the path I picked.
Yeah. So yeah, it seems like if you're curious and restless, this might at least give you more space than other specialties, maybe to explore new things. Speaking of your book again, is there any story from the book? As someone who hasn't read the entire book, I have to admit, how is it structured? Can you share maybe a little story, a nugget from the book to get the audience excited?
Well, I started off telling like my background of why am I talking about this. And so I go
Mm,
back to like when I was a Girl Scout and getting my gold award and was really focused on teaching adolescents around sexual health. It's just always been an interest area of mine. To the very first um, AIDS quilt when in the 1980s, going to DC and seeing that first quilt spread out on the lawn and understanding for the first time as a high schooler that people were dying
mm.
because of sex in a way that didn't make any sense and I didn't understand. So I kind of tell the story of how I got interested in this path, and then I go into the different, like why now, and the different types of infections, bacterial and viral, and then what's normal, what's not normal. So I help unpack that there's a lot of normal genital stuff that happens that's not a sexually transmitted infection, and then that chapter around how to talk about it. So as I was writing the book, I asked my mom if she would read an early copy of it and give me her thoughts. And she calls me and she goes, I just don't understand. I don't understand. And she was about 75 at the time. And I was like, what don't you understand? And she goes, well, how would anyone have that conversation with somebody? And I said, what are you talking about? She goes, well, you're talking about in that whole chapter about dating apps that people are supposed to talk to people about whether they've had a test done. I can't imagine having that conversation. And so after that call with her, I thought, huh. So I put in scenarios of like different scenarios so people could practice out loud in front of their mirrors, asking these questions that make them blush and feel uncomfortable so that when they have that conversation, it doesn't feel as awkward and weird to them. And so that was sort of her influence on the book. But I tell tons of stories of patients over the years that I cared for, and some stories funny, some stories sad, but all of them just very true and based in real life experiences.
Yeah, it sounds like a very interesting read. I'll make sure to link it below the video or below the audio podcast, depending on where you listen. Very
You can
interesting.
also get it on Audible, right? So you can get the
Oh,
audiobook.
yeah.
And here's another thing for people that have commutes that don't, have time to read actual books. They called me to say that there was an audiobook that wanted to pick it up. And I'm like, oh, great. When do I record it? And they said, no, no, you don't get to record it. There'll be an actor that records it. I'm like, it's my book. I want to record it. And so they're like, well, you can audition to be you. And so I had to audition to be myself. And as I was doing this audition, I was like, look, guys, I got to be honest. No one's going to say these words. You're not going to find anybody that wants to read this book out loud. But I got cast as myself and I got to be myself and read my audiobook. So that was kind of fun.
That's great. Yeah. And yeah, it sounds like it's harder than it should be to be cast as yourself. This is who's gonna do that better than you, right?
Well, apparently some writers have really terrible voices
Yeah.
and are not good at speaking out loud. So I got by with it.
True, and maybe with the added advantage that medical terminology isn't always easy to pronounce, and maybe also the more specific sexual terminology, not everyone is comfortable with that. Who knows? Maybe that plays a role as well. Cool, yeah, but like I'm wondering if you look back, like a lot of listeners are maybe at the beginning of their careers and are wondering, like, how can I get into like interesting other areas? And looking back at your career, would you do anything differently, or is there any advice that you would give yourself maybe to make some choices a little bit easier, or are you particularly happy with how everything went? Is there any type of advice you would give your younger self or anyone else listening?
Think the most important thing for me in my career has been mentorship and having really strong mentors who helped me think of myself differently or imagine myself doing things that I hadn't imagined myself doing. And so finding those mentors early on is really important, and forming actual real relationships with them. I have young people all the time ask me, they'll send me an email and they'd be like, Dr. Dowler, I saw your talk on whatever. Would you be my mentor? And that's not really how mentorship works. It's around that sort of authentic connection that you make with people in your pathway. So whether you're a medical student, a pre-med student, I had mentors before I even went to medical school. For me, they were mostly women that were more experienced in the professional world than me, who just took me under their wing and took the time to guide me and offer advice and help de-escalate me when I'd get all agitated about things. So I think not only seeking mentorship, but being a mentor. It takes a lot of time and energy to be a mentor, but it's worth it. And it's really important for all of us to think back to who are we mentoring right now? And have we mentored anyone recently? And if not, we probably need to extend ourselves a little bit more because mentors are the critical piece. And would I
Yeah.
go back and do things differently? I don't think I would. I think every experience I had, good or bad, helped shape who I am and helped me get to the next stage of my career path. So I sort of went where the universe directed me a lot of the time, and that worked out really well. Not having a lot of doubts or questions or second guessing decisions, just know that what you're doing in this moment, whether it feels great or not, is probably preparing you for whatever that next thing is, and be open to the next thing. I have friends who won't change jobs no matter what. They're so risk averse. And so they stay in miserable jobs for year after year, decade after decade of what you're doing and the way you're living your life as a physician. Is it working for you and helping you be your best self?
Great advice. Thank you so much, Shannon. This has been a real pleasure. Thanks for being here.
Absolutely.
Thank you for listening to Medical Portraits. If you enjoyed this episode and want to hear more inspiring stories from the world of medicine, make sure to subscribe to the podcast. See you in 2 weeks.